Imagine searching for, like, an actual anatomical organ that half the medical community swears exists and the other half says it's a complete ghost.
Right. It's wild.
Because we are so used to medicine being precise, like
Yeah,
engineering. You break your arm, the x-ray shows a jagged white line, and the doctor just points to it.
exactly. It's visible. It's perfectly mapped out.
But then you step into the world of female sexual anatomy, and that x-ray machine suddenly just, well, it stops working. We end up looking at a diagnostic landscape that is just incredibly murky.
I mean, the historical search for a singular magic button of female pleasure is the absolute definition of diagnostic muddy waters.
Yeah.
But when you look past all the cultural mythology, you find something much more complex. You find the actual tissue mechanics of human biology.
Which is exactly what we are jumping into today. For this deep dive, you, our listener, provided us with a truly fascinating stack of materials.
Some really dense stuff, too.
Oh, absolutely. We are looking at these thick clinical studies on pelvic floor biomechanics and vaginal tissue displacement from the American Urogynecologic Society and AUA journals.
Right.
And we are cross-referencing those studies with very practical, on-the-ground materials from aesthetic gynecology clinics all over the globe. We're talking Paris, Miami, Singapore, London, and Dubai.
And our mission today is to cut through all the noise. We are going to decode whether the G-spot actually exists anatomically, what a clinical procedure known as the G-shot physically does to the body, and honestly, how altering vaginal biomechanics can fundamentally change a person's sexual experience.
Because, as you're going to hear, this entire topic is surprisingly physics-driven. I mean, it's all physics.
It really is.
But before we can even begin to understand how a medical procedure attempts to augment this area, we have to address the elephant in the room. The decades-old controversy.
The big question.
Right. What exactly is the G-spot? Like, does it even exist as a distinct standalone organ?
So to understand the confusion here, we have to go back to the 1950s. The term itself is actually named after Dr. Ernst Grafenberg, who's a German physician. And he was the first to formally document a highly sensitive erogenous zone located on the anterior, meaning the front vaginal wall, right along the urethra.
Right. The G in G-spot is for Grafenberg.
Exactly. And during his examinations, he noted that when a patient was aroused, this specific area would swell, almost like a small cystocele.
Wait, let me stop you there. It swells like a cystocele. What exactly is that?
Right, sorry. So a cystocele is essentially a structural bulge. It happens when the supportive tissue between a woman's bladder and vaginal wall weakens.
Oh, okay.
And that allows the bladder to sort of bulge into the vagina. Now, Grafenberg wasn't saying the arousal swelling was an actual medical hernia.
Oh, he's just using it as a visual.
Exactly. He used that visual to describe how this sensitive tissue physically puffed out, and ballooned downward into the vaginal canal during arousal.
So he sees this physical swelling, he documents it, and basically sets off a 70-year scientific scavenger hunt.
That is exactly what happened.
Because in the sources you sent us, there is this fascinating study by a researcher named Dr. Ostrozensky.
Oh, yes, the cadaver study.
Yeah. He dissected the cadaver of an 83-year-old woman and claimed to have found the Holy Grail. Like, he described finding a distinct blue, grape-like structure of erectile tissue buried deep in the front wall of the vagina.
And he published those findings with absolute certainty. Like, he was very confident.
But the broader scientific community pushed back hard on that.
Oh, massively. Other researchers pointed out the immense difficulty of finding erectile tissue in a cadaver. I mean, erectile tissue only becomes prominent when it is engorged with blood.
Which a cadaver obviously doesn't have.
Precisely the issue.
Sure.
And beyond that single dissection, there are multiple other exhaustive anatomical reviews, like the really comprehensive studies published by Hogig and colleagues.
Right, I saw those in the stack.
Yeah, and they state categorically that there is no distinct macroscopic structure evident on anatomical dissection of the vaginal wall. They essentially mapped the entire area millimeter by millimeter, and concluded that there is no isolated, standalone organ there.
So we have one side holding up a blue grape and another side saying, no, the map is completely empty.
It's a total contradiction.
It's no wonder patients and even doctors are just completely confused by this. Let me try an analogy here to see if I'm understanding the modern consensus.
Go for it.
So it's not a distinct hidden button you press to trigger a response, like a single key on a computer keyboard. It's more like a functional zone on a smartphone touchscreen.
Oh, I like that.
Right. Like the screen itself looks flat, but underneath there is this dense network of sensors, nerves, and wires that all work together to register a specific type of input.
What's fascinating here is how the scientific community's understanding has evolved to align almost perfectly with that touchscreen analogy. Yeah, the modern medical consensus is shifting rapidly away from the concept of a singular spot. Instead, urogynecologists and anatomists now refer to it as the clitorethrovaginal complex, or the CUV complex for short.
The CUV complex, that definitely sounds more like a system than a spot.
It is an entire dynamic ecosystem. It's a highly vascular, densely innervated functional zone.
Wow.
Yeah, and it encompasses the internal hidden roots of the clitoris, the urethra itself, and the anterior vaginal wall. None of these operate in isolation.
They all work together.
Exactly. They are a biomechanical system that relies entirely on tissue health, robust blood flow, and engorgement. When this entire complex receives the right mechanical stimulation, it can lead to a vaginally activated orgasm.
Okay, let's unpack this, because if the G-spot is actually this complex dynamic tissue zone, the CUV complex, rather than a fixed hard button, how do medical professionals even attempt to enhance it?
That is the big question.
Because looking at the materials from the clinics in London and Dubai, the answer seems to be by physically engineering the volume of the tissue. Enter the G-shot.
Right. So the G-shot, which is also heavily marketed as G-spot amplification, was originally developed by a U.S. gynecologist named Dr. David Matlock.
Okay.
And the entire premise of the procedure is to artificially engineer that tissue volume.
Now, looking at the clinical breakdown, this seems surprisingly fast for a procedure that actually alters human anatomy. Like, how invasive is this, really? What is physically happening in the exam room?
It is essentially a 15 to 30-minute outpatient procedure, and is performed under local anesthesia.
That's incredibly quick.
It is. The physician first locates that sensitive CUV zone on the anterior vaginal wall, which is usually about 2 to 3 inches inside the vaginal canal.
Okay.
Once the target area is identified, they inject a synthetic filler directly into the submucosal layer, just under the muscularis of the urethra.
I'm going to need some translations for that anatomy.
Sure.
What is the submucosal layer and what is the muscularis?
Think of the vaginal wall as having layers, kind of like a layered cake.
Okay, a cake. I can picture that.
The very top layer, the icing, is the mucosa. That's the surface lining. Just underneath that icing is the submucosal layer, which is a spongy, supportive cushion of connective tissue.
Got it. The cushion.
Right. And below that cushion is the muscularis, which is the actual muscle layer that surrounds the urethra. The physician is aiming the needle specifically into that middle spongy cushion layer.
So right into the middle of the cake?
Exactly.
Yeah.
And the needle itself only goes about 3 to 5 millimeters deep. The actual injection takes maybe 5 to 10 seconds.
Only 3 to 5 millimeters. That is incredibly shallow.
Very shallow.
But I have to push back a little on the substance they are injecting. The clinical data states the filler used is usually hyaluronic acid or sometimes, a collagen base.
That's right.
But hyaluronic acid is the exact same substance dermatologists use in facial dermal fillers, like for plumping up lips or smoothing wrinkles.
It is the exact same stuff.
How in the world can a simple cosmetic facial filler instantly alter something as complex as female sexual function?
It all comes down to the unique molecular properties of hyaluronic acid and really how it interacts with the local anatomy.
Okay.
Hyaluronic acid is a hydrophilic molecule, meaning it naturally attracts and tightly binds to water. I mean, it can hold up to 1,000 times its weight in water.
Wow. 1,000 times.
Yeah, so when a physician injects it into that spongy submucosal space, it aggressively pulls in surrounding fluid and creates an instant localized tissue protrusion.
The clinic data from Singapore actually mentions this. They say it creates a physical bump about the size of a Singapore 20-cent coin, or, for the UK clinics, a 5p coin.
It literally builds a mound inside the vaginal canal. But it's crucial to understand what this filler is not doing.
Right, because it's just a filler.
Exactly. Adding this localized volume does not create new nerve endings. The injection isn't magically sprouting new sensory receptors.
It's just water and acid.
Right. What it is doing is physically changing the internal structural landscape to make the existing nerves in the CUV complex more prominent, and therefore more physically accessible during penetration.
And because the body naturally metabolizes and absorbs hyaluronic acid over time, these structural effects are temporary, right? Lasting anywhere from 3 to 12 months before returning to baseline.
Correct. It is a temporary structural scaffold.
Here's where it gets really interesting. This brings us to the core physics of this deep dive.
Yes. The physics.
As you're listening to this, you might be wondering, if this is just a temporary blob of hyaluronic acid, how does that actually change the physical sensation?
That's a great question.
The answer isn't chemical, it's not hormonal, it is pure, unadulterated biomechanics. We are talking about altering the physical forces during intimacy.
To truly grasp why this works for so many patients, we have to look really closely at friction vectors and anatomical congruence.
Let's use an analogy to visualize this. Imagine a completely flat road.
Okay, flat road.
If you drive a car over it, the tires just glide. There's very little targeted impact on the road surface. But if you pour a massive speed bump on that flat road, the car can no longer just glide over it.
Right. It hits it hard.
Exactly. The car, or in the context of our discussion, the friction of penetrative intercourse hits that newly engineered bump with significant direct mechanical impact.
That speed bump analogy is the exact mechanism at play here. By artificially ballooning the anterior vaginal wall forward into the vaginal lumen, which is the open space of the canal, the G-shot artificially decreases the urethrovaginal space.
It pushes the sensitive tissue out into the line of traffic.
Yes. The clinical sources from Dr. Santini's clinic in Paris actually refer to this as pushing the structures caudally.
Caudally. I'm assuming that means pushing them downward or like outward into the open canal.
That's right. Caudally means toward the tail, or in this context, protruding downward into the open vaginal canal. And this artificial projection allows for what the clinics call better congruence of the sexual organs.
Congruence, meaning things fit together better.
Precisely. By pushing the highly innervated CUV structures caudally, it brings that tissue into much closer, tighter contact with whatever is inside the vaginal canal, whether that is a partner's penis, fingers, or a toy.
And this plays a massive role when we talk about variations in partner anatomy, doesn't it? Because human bodies come in wildly different shapes and sizes.
Oh, absolutely. It's a huge factor.
Right, because sometimes a partner's specific size, shape, or even just the natural angle of penetration just doesn't optimally align with where a woman's CUV complex happens to be located.
This is a very common clinical reality that constantly gets overlooked when people talk about sexual dysfunction.
Really?
Yeah. If the target zone is flat against the ceiling of the anterior wall, standard angles of penetration combined with variations in a partner's anatomy, say differences in girth or length, can completely bypass those sensitive tissues.
So they just glide right past it.
Exactly. The natural anatomical alignment just isn't always conducive to stimulating that specific nerve network. It's an alignment issue, not a dysfunction issue.
So the G-shot essentially creates a bridge. This added projection from the hyaluronic acid filler compensates for those anatomical variations in partner size.
It does. It bridges the gap.
By making the target larger and more prominent, it fundamentally alters the friction vectors. It dramatically increases the contact surface area between the CUV complex and the penetrating object.
Regardless of the partner's specific anatomy or the angle of penetration, that engineered speed bump ensures that the nerve-dense tissue is going to receive targeted mechanical stimulation.
That is wild.
The friction vectors are literally redirected to hit the bullseye.
And we actually have incredible data backing this up from the biomechanical studies you provided in the source stack. I'm talking specifically about the studies utilizing something called vaginal tactile imaging and aspiration devices.
Yes.
These studies absolutely blew my mind.
The tactile imaging research is groundbreaking. Researchers use these specialized tiny suction and pressure mapping devices inside the vagina to measure how the tissue displaces under a physical load.
So they are essentially measuring the squishiness and elasticity of the vaginal wall in real time.
I mean, that is a highly technical way to put it, but yes.
Squishiness is a very scientific term.
Of course. And what these complex biomechanical mapping studies show is that women who naturally easily experience vaginal orgasms tend to have a thicker, stiffer urethrovaginal space.
Wait, a stiffer space?
Yes.
Usually when we talk about biological tissue and health, we assume softer and more pliable is better. Why would stiffer tissue lead to better sensation?
It seems totally counterintuitive until you look at the transmission of mechanical force. Think of the tissue like a drum skin.
Okay, a drum skin.
If a drum skin is loose, soft, and lax, striking it with a drumstick won't produce much vibration. The energy just gets absorbed and lost in the loose material.
Right, it just thuds.
But if that drum skin is thick and pulled tightly taut, it transmits the mechanical force of the drumstick beautifully, creating a loud, resonating sound.
And the pelvic floor physics work the exact same way.
They do. A stiffer, thicker tissue response transmits the mechanical force, meaning the friction of intercourse, to the deeper nerve endings of the CUV complex much more efficiently than lax, loose tissue.
So, if a patient has lax tissue, perhaps from aging, childbirth, or just genetics, the friction vectors from penetrative sex are weak. The mechanical force just dissipates into the loose tissue before it ever even reaches the deep nerve endings.
Exactly. It gets lost.
But by injecting hyaluronic acid, the G-shot artificially thickens and stiffens that localized area. It engineers a better drum skin, ensuring the mechanical force is transmitted directly to where it needs to go.
For decades, female orgasm has been studied predominantly from a psychological or hormonal perspective.
Right, we look at estrogen levels or relationship dynamic.
Exactly. But this specific urogynecologic research forces us to look at it from a strictly biomechanical perspective. Pelvic floor muscles, anatomical congruence, and tissue displacement are critical foundational components of sexual satisfaction.
So what does this all mean for the patient looking at their actual medical options? Because while the G-shot is essentially a brilliant mechanical fix, adding a structural speed bump to maximize friction vectors, your sources also detail another procedure called the O-shot.
Yes, the O shot.
Does the medical field have a way to actually heal or rebuild that tissue organically rather than just propping it up with a synthetic filler?
That question represents the essential dividing line in aesthetic and regenerative gynecology right now. As we establish, the G-shot uses hyaluronic acid to artificially increase volume and friction.
Right.
It's a temporary structural filler. But the O-shot, which stands for orgasm shot, takes a completely different biological approach.
Because looking at the literature from the Miami and London clinics, the O-shot doesn't use a synthetic filler at all. It uses PRP platelet-rich plasma,
Exactly. The O-shot utilizes PRP derived entirely from the patient's own blood.
which is pretty intense.
It is. The process involves drawing a small amount of the patient's blood, spinning it in a specialized centrifuge to isolate the highly concentrated growth factors and platelets, and then injecting that plasma directly into the clitoris and the anterior vaginal wall.
So the goal here isn't to create a physical speed bump to alter friction vectors. The goal is to stimulate actual cellular tissue regeneration.
Biological healing from the inside out.
Ah, I see.
The growth factors in the PRP actively promote a process called neovascularization, which is the creation of new microscopic blood vessels.
Oh, wow.
Yeah. This increased blood flow aims to improve inherent nerve sensitivity, rejuvenate the mucosal lining, and increase natural lubrication.
Because it's actual healthy tissue now.
Right. And because the O-shot relies on the body actually growing new, healthier tissue, the results take a little longer to manifest, usually a few weeks. But they can last much longer than a synthetic filler, typically anywhere from 12 to 18 months.
If we connect this to the bigger picture...
Wait, I think you're stealing my line.
Oh, you're right. My apologies. Take it away.
If we connect this to the bigger picture, you are looking at two vastly different clinical philosophies. The G-shot is a targeted structural intervention designed to change the physics of intercourse, while the O-shot is a biological intervention designed to rejuvenate the cellular health of the tissue itself.
Which makes total sense when you lay it out like that.
And it is vital to impartially state, as all the clinical literature heavily emphasizes, that these procedures are not FDA approved for these specific sexual enhancement uses.
Right, they are considered off-label.
Yes, they are performed off-label and remain pretty debated within the broader traditional medical community.
Which is exactly why managing patient expectations is so heavily stressed in every single clinic brochure we reviewed. Because, as brilliantly physics-driven as the G-shot is, a mechanical speed bump cannot fix a complex systemic issue.
It absolutely cannot. Human sexual response and orgasm are deeply multifactorial. They rely on psychological states, relational dynamics, emotional well-being, past trauma, and delicate hormonal balances.
Right.
A G-shot does not and cannot cure low libido.
Yeah.
If the underlying desire isn't there, or if a patient is experiencing psychological distress, simply adding volume to the vaginal wall will not solve the problem.
Furthermore, human anatomy is beautifully diverse. The sources are very clear that some women naturally orgasm predominantly or even exclusively from external clitoral stimulation.
Very true.
For those women, the internal CUV complex simply might not be their primary trigger for climax. And if that is the case, a G-shot may have little to no effect regardless of how much you alter the friction vectors inside the canal.
It all comes back to understanding the unique mechanics of your own body. As the InSync medical source out of Singapore wonderfully notes, they say, not all women will find satisfaction through G-spot stimulation. And that's fine too.
Exactly.
The goal of these medical interventions isn't to force everybody into one specific mold. It is to offer scientific tools for those who do desire that specific type of internal stimulation, but are finding their natural anatomy isn't cooperating.
It's about providing a tool for anatomical congruence, not a magic wand for all sexual issues. So let's bring this all together for you listeners.
Let's do it.
We started this journey looking for a magical, distinct, singular organ called the G-spot. What we found instead is that it's highly likely a complex, interconnected functional zone, the clitorethravaginal complex.
And we discovered that clinical procedures like the G-shot work not by creating new nerve endings out of thin air, but by temporarily altering vaginal biomechanics.
By adding that speed bump.
Right. By using a hydrophilic filler to increase volume, the procedure maximizes friction vectors and radically improves anatomical congruence during penetration. And that compensates for natural tissue laxity or variations in partner size.
It's all about ensuring the mechanical force of intimacy actually reaches the nerve endings that matter. And for you listening, understanding the pure, unadulterated mechanics of your own body can be incredibly empowering.
It really is.
It removes the mystery, the shame, and the historical stigma from female sexual satisfaction. It takes the conversation out of the realm of something must be wrong with me and puts it into the practical scientific realm of, oh, my friction vectors are just misaligned.
This raises an important question, though. There's a fascinating, almost futuristic concept mentioned deep in the urogynecology sources regarding pelvic tissues and mechanical loading.
Oh, you mean the bioengineering use it or lose it rule?
Yes. Like many tissues in the human body, such as muscle or bone, pelvic floor tissues follow a strict rule of mechanical loading. If the tissue isn't regularly subjected to physical mechanical forces, the body assumes it isn't needed,
So it just gives up on it.
basically.
Mhm.
When that happens, the structural collagen degrades. The tissue literally atrophies and loses its stiffness simply from a lack of mechanical stimulation.
Which is wild to think about in this context. If the vaginal tissue is naturally lax, the friction of intimacy doesn't hit the CUV complex.
Right.
Because the friction doesn't hit it, there is no mechanical loading. And because there is no mechanical loading, the body stops maintaining the collagen in that area. It becomes a vicious biological cycle of losing sensation.
It is a feedback loop of atrophy, which leaves us with a truly provocative thought to ponder based on these sources.
Let's hear it.
If we can artificially alter the physical mechanics of pleasure with something like a G-shot, if we can artificially create that speed bump and restore the regular physical friction and mechanical loading to that tissue,
Wait, could restoring that targeted physical friction actually prompt the body to organically rebuild its own collagen and nerve responses over time?
that's the theory.
Like, could a temporary mechanical fix actually jumpstart a permanent biological healing process by forcing the body to recognize that tissue again?
It is an incredible question, and one that the intersecting fields of urogynecology and biomechanics are really only just beginning to ask.
It makes you rethink everything we thought we knew about anatomy. We started this deep dive talking about that clean binary X-ray showing a simple broken bone. We walked into a diagnostic landscape that seemed murky, controversial, and honestly confusing.
Very confusing.
But when you look closely, when you map the friction vectors, account for anatomical congruence and partner size, and understand the core physics of tissue displacement, the muddy waters clear up. The map of human pleasure isn't binary, but it absolutely follows the laws of physics.
And understanding those laws is the first step to truly mastering them.
Beautifully said. Thanks for taking this deep dive with us.